Disclaimer. This episode contains discussions of a death investigated as a possible suicide, including detailed descriptions of evidence, injuries, and investigative findings. Please take care while listening. Greetings, and welcome to Love and Justice. On our last episode, we moved through the investigation timeline. We also began asking forensic experts from around the world a difficult but necessary question. How is this even possible? Could one person really inflict this many wounds upon themselves? Could they remain conscious while doing so? And as we started to hear, the answer was not a simple yes or no. Again and again, our experts came back to the same narrow space. It's possible, but unusual. It's possible, but rare. And that brings us to our next question. If the physical evidence asks whether Andrew could have done this to himself, the psychological evidence asks something different. What would have to be happening inside a person's mind for suicide to be possible? Before we can responsibly talk about the autopsies, we should understand the psychological side of this controversial determination. In a case that's involving 29 stab wounds, a sober toxicology report, and loved ones who still say the determination never matched the person they knew, the question is not just whether suicide is possible, but rather what would make it plausible. To better understand that question, we reached out to Dr. David Jobes.
I'm Dr. David Jobes. I'm a professor of psychology at Catholic University in Washington, D.C., and I have spent my career studying suicide. Specifically, I've developed a treatment, and so we do randomized controlled trials of this treatment. But I've worked in policy, forensic work. I'm a clinician, and so I have breadth and depth expertise in suicide prevention.
I'm curious, when people hear about this case, the kind of immediate reaction from most people is just disbelief. From a psychological standpoint, what actually makes something like this possible?
Well, what makes something like this possible, Kyle, would be acute psychosis. You know, somebody who's really, really out of touch with reality. It's very uncommon for someone to stab themselves that many times unless they're acutely psychotic. We see some suicides that occur where people might do something very out of the ordinary. But for most people who intend to end their life, they do something fairly straightforward that doesn't require repeated actions to achieve that outcome.
I think perhaps the hardest for the family is the fact that the toxicology reports came back. Andrew was sober. When we hear that he was sober, is that just a very rare lightning hitting at the right spot thing that spurs that? What brings something like this about?
So that, again, is unusual. Many suicides occur when people are intoxicated or are otherwise inebriated or high. Some people will talk about liquid courage. It's a way to kind of overcome the hesitancy to take one's life. You know, there's a controversy in the field about the idea of sudden suicides where you just had no idea. No run-up, there were no suicide notes, there was no communications. It just seemingly came out of the blue. And different experts in my field will say that that's just not a thing, that people have pre-morbid thoughts or ideation, maybe sitting on a shelf, so to speak, in their mind, and then they get in the moment, perfect storm, things happen, and they take it off the shelf. But it would not be typical that I would do this with you and then walk out in front of a car. I mean, there's usually a very clear history. When we do psychological autopsies, Kyle, we can oftentimes see a way that people got to this moment, and it's not altogether surprising. So all that is oftentimes in play in the determination of the manner of death.
And I'm glad you brought that up because that perfectly segues into another thing that I think so many people that are close to this case, that were close with Andrew, struggle with, They acknowledge that when somebody does commit suicide, there's often that hindsight, right? You go back and say, oh, well, I know he was struggling with this and that. And then you can start to say, well, obviously incredibly unfortunate, I see a bigger picture that maybe we missed in hindsight. Here, family and friends and everybody are like, he had things going for him. He wasn't struggling financially. He had a girlfriend. He had plans. He knew what he wanted to do after college. And they remain kind of steadfast in their belief 25 years later that, this was uncharacteristic. When you see cases like this, what do you make of that? Can cases where there is no hindsight exist in what you see, or is that also a rarity?
They're pretty rare. I think the vast majority of cases, if you're talking to loved ones, if a psychological autopsy is conducted and enough people are interviewed, like, yeah, he did drop this hint, or she said that, or there was an email or social media post that seemed a little bit off. In my experience, it's more common that people work their way there. They have thoughts, or they have fantasies, or they've done some internet research. I mean, we're mostly wired evolutionarily to want to survive and live. So what it psychologically takes to override that desire to live is a lot of suffering and a lot of shame and disappointment or trauma or things that kind of overrun the person so they feel like this is the only thing I can do to deal with my circumstances.
We're mentioning in this conversation about how rare some of these kind of subsets of this particular story are. Are there documented cases that are similar in nature to what we're hearing here that kind of challenge our assumptions about what a person can or can't do to themselves in a sober state?
Well, someone sober and psychotic, they can still hear command hallucinations telling them to kill themselves or destroy this part of their body. That is conceivable. It's not common, fairly rare. And there would be a history probably of psychosis and or schizophrenia or a thought disorder or psychotic disorder.
Something you said at the beginning of that spawned another kind of question in my head that's a bit of a follow-up to it, which is you mentioned that, yes, there is a world in which, while rare, people can get into this acute psychosis to cause this kind of physical harm, multiple times, stab wounds. But what it sounded like, and I want to make sure I'm understanding what you're saying correctly, is that it would be very unlikely that you would have never seen a warning sign before that particular instance. Would that be safe to say?
It depends. I mean, schizophrenia, how old was the deceased?
20.
I mean, there's a form of early schizophrenia where there's a psychotic break in the early 20s. It can be very severe. The hallucinations and the distortions in reality are extreme and severe. And it can seem to kind of come out of the blue. I'm not suggesting that he was schizophrenic, but that is a kind of onset that would not be entirely unusual for a young 20-year-old male. But again, it's hard to imagine that this was his first psychotic break and this was the behavior that resulted from that. Is it possible? Of course it's possible, but it would be very rare.
Mm-hmm. What are common mistakes that the public or even investigators might make when evaluating whether a death fits psychologically?
Well, there are all kinds of mistakes that are made. There are some medical examiners or coroners that will only certify a suicide in the presence of a suicide note. At least that back in the day, that was the case. And if that's your policy, and only 20% of people that die by suicide leave a note, then you're going to miss a lot of suicides. And then there are different systems in our nation. Uribe contributes to the centralized database at the National Center for Health Statistics. There's a wide range of people that certify these deaths, of varying degrees of qualification and competency. And so if you're in a small town and everybody knows everybody, if you're a friend of the family, you might be reluctant to certify a suicide if it means that it's embarrassing to the family. So there are all kinds of considerations that go into the validity of a medical legal certification of manner of death.
You just brought up suicide notes, which in this case, there was a note that was found with Andrew. A lot of people talk about how this note was very vague. It started off, "Dear World," as opposed to being written to any one particular person. Are there psychological characteristics that you generally look for with notes that lead one to say, like, most notes are addressed to a particular person versus something else?
Yes. So there's a lot of research of what's characteristic of notes. There's a construct in the field called perceived burdensomeness. A lot of times the note will say, you'll be better off without me. And I'm sorry, this is what I had to do. But at the end of the day, I'm such a difficult person and have caused you so much suffering that this is a gift. That's what they perceive. Sometimes suicide notes are very businesslike, like do this with this and do that with that. And these are my wishes for the funeral. Oftentimes, it's an explanation to the loved ones of why I did what I did and that I'm sorry, things along those lines. I will say, in our most recent clinical trials, college students and teenagers are kind of in the dear world state, but this case is very old. You can't really say a generalization that covers everything, and there's a broad range of how people write suicide notes. Has the suicide note in this case been authenticated? Was it in his hand?
They authenticated the note to say that it was in his handwriting. They believe it was not done under duress, but I think there's some questions around what that study looked like. Of course, there's been a little bit of chatter about how handwriting analysis has come over the last 25 years and whether that might be something worth reevaluating as well. So there's some ambiguity there for sure.
Yeah. I mean, I think these days they're pretty good at analyzing handwriting and probably getting it right. And if the note was written without distress, that would be an argument for. But you just don't know. So that's what makes these cases so heartbreaking. I'd be curious about the specifics of the suicide note, and it could be very dear world existential. That wouldn't be surprising to me. But it makes for any more complex case to kind of think of who would be the perpetrator and how would they have gotten away with such a severe act of assault.
I can pull up the suicide note. I got it here. This was found next to Andrew's bed. Dear world, I am only doing this because I have no other choice. I can no longer take care of myself and don't want others to have to do it for me. I can't tell what's right or wrong anymore, and I don't want to hurt anyone. Thank you all for loving me. I hope to see you in heaven.
That's not an atypical suicide note, and it does allude to the perceived burdensomeness. It does allude to a compromise in reality testing, that maybe he's not able to care for himself. Don't know what that really means. Might I ask, what were the I hate to be graphic about this, but it's kind of where people go with this. What were the circumstances of the body and the placement of the knife and so forth?
Andrew was found in his bed, tucked into bed. There was different pieces of evidence that had blood on it, including like his computer speakers and things like that around the room. Notably, the note did not have blood on it, which is a very kind of interest thing to a lot of people, including what the initial report said.
Where was the note in terms of the placement in the room?
The note was on his computer desk, which was, it was a fraternity dorm room, so it wasn't that big of a room, right? So not far from the bed. The knife was found on the bed near his left hand, but not in his hand.
Was he left-handed?
He was right-handed.
This is the kind of stuff that somebody who really knows the business would look at. You'd be hard-pressed to take somebody who is right-handed to be stabbing themselves with their left hand. That's the kind of thing that doesn't add up.
Mm-hmm.
So there's enough in this case to kind of make it obviously very complex and confusing. I'm sure it's heart-wrenching for the family. It's a very unusual case in that regard.
If somebody were trying to responsibly explore a case like this deeper, much like we are, what questions should they be asking that maybe often get overlooked?
Are you talking about opening the case up, having it reinvestigated?
Perhaps, yeah.
I would get the top MD, PhD forensic pathologist to look at the physical evidence in the autopsy, the nature of the stab wounds, to discern if this highly unusual scenario could be enacted by the decedent. And if so, why so many, I don't mean to be crass, but it's pretty easy to end your life with a single stab wound. So what's the additional stabbings and inflictions? It would certainly have been painful, or certainly be a lot of blood loss. That's where I go, is like the physical evidence. It sounds to me like that would be where to start. And what a psychological autopsy would be is getting a very detailed, systematic set of interviews, talking to girlfriend, talking to parents, talking to teachers, professors, classmates, people in his fraternity, and then looking at toxicology, autopsy, I would think that a really good forensic pathologist would have a lot to say about the nature of the stab wound. Was this physically possible for an individual to do this to themselves? And kind of putting that all together and saying, yeah, it looks like the intentionality was this or that, without anybody ever knowing for certain if it's true. These things are so emotional, understandably. These deaths are so emotional. No matter what the truth is, it will never bring him back. Every family and loss survivor has to deal with that. And the implications are far-reaching. If there's insurance policy, oftentimes there's a double indemnity clause that the named people on the policy will not get the full payout if it's a suicide, manner of death, versus a homicide or accident or other manner of death. And then there's all the stigma that comes with it. So there's a lot of forces at work that enter into the investigation, that enter in the determination of the manner of death, and then just all the wretchedness that no matter how he died, it was a horrible way to die. It really does go to the heart of the matter in terms of a mysterious case like this, because every way you look with this case, it's unusual and atypical. And that's what makes it, on the one hand, fascinating, on the other hand, especially tragic.
Yeah, very much so. Dr. Jobs paints a very helpful understanding of the psychological territory that this case asks us to enter. But while we are on a deep dive of the psychological side of things, we should travel down one more rabbit hole. Andrew had reportedly been dealing with strep throat over the winter break and took a round of antibiotics. Could strep throat itself, or common strep throat medications, plausibly cause dramatic psychological symptoms in an otherwise healthy 20-year-old? In one medical review published in 2005, pediatric neurologist Russell Dale looked at a growing body of research around post-strep autoimmune disorders of the central nervous system. The study found that strep can sometimes trigger immune responses that affect the brain, and those effects may show up not only as physical symptoms, but also as changes in movement, mood, behavior, and sleep. But strep itself is only one part of the question. If Andrew was being treated for strep, then we also had to ask about the medications commonly used to treat it, what they do, what side effects are known, and whether any could plausibly affect Andrew's mood or behavior. For that, we spoke with a licensed pharmacist.
My name's Brian Hoppy, coming up on almost 9 years of being a licensed pharmacist. What we typically see, if they for sure have a case of strep throat that's been confirmed with throat cultures, that it's actually bacterial, because normally only in maybe 5-10% of strep throat cases, it's actually bacterial. Very run-of-the-mill you're going to get is amoxicillin. Maybe sometimes penicillin, but at least in my experience, per IDSA guidelines, CDC guidelines, you're getting amoxicillin. If you are looking at these types of antibiotics, penicillins, amoxicillin, just on a daily sort of basis, for an otherwise healthy person, you're not going to be experiencing anything psychological in any which way, shape, or form. Now, I did come across a very rare case report of it potentially happening, but this was because they had a lot of other things happening. In a regular healthy person, it's almost not possible. If anything, extremely rarely. Now, if you start to get into your second line, I did see that there are cases, especially with clarithromycin, there are much more case reports relating to those neuropsychological type effects. The only reason why they would immediately jump from amoxicillin, penicillin to a second-line antibiotic in any case, it would purely only be if they had an allergic reaction. If they were allergic to penicillins, you're automatically being put on one of those second-line antibiotics.
And we know that Andrew was not allergic to penicillin. We've talked to his family. They were able to confirm that. So that likely would not have played into account. But let me ask you this. If somebody was drinking or smoking marijuana, as we know these college kids were, at the end of a treatment for strep throat, is there a chance that that throws everything out of orbit and that you may start to see a psychological side effect here?
So, Kyle, I think that's a very good question. Alcohol and marijuana very much are studied, can affect how medications in the most general sense work, especially marijuana. We have synthesized so many different compounds that can affect a wide variety of medications. So in regards to antibiotics, even amoxicillin, penicillin, one of those risk factors that can put you at a higher risk of any sort of neuropsychological effects could be anything, any drug, any substance that affects the brain. So yes, alcohol and marijuana does have the potential to increase that risk. How high that risk is, I honestly don't know. That's kind of hard to say. It's very patient specific, and I don't think there's a whole lot of evidence out there to actually share exactly how much is affected by alcohol or marijuana.
So let's recap. The psychological explanation is possible, but unusual. The medication explanation, at least with first-line strep antibiotics, appears extremely unlikely in a healthy person. Strep-related neurological effects are both rare and complicated. But none of this resolves what Andrew's body showed. Which brings us to the autopsy. When Andrew died, there was not just one medical examination of his body. There were two. The first autopsy was performed by Dr. Arnold Joselson, a board-certified medical examiner under contract with the Yolo County Coroner's Office. The autopsy was performed the day after Andrew's body was discovered. The second autopsy was performed over a month later by Dr. John T. Cooper, another board-certified forensic pathologist hired by Andrew's family. Now, it's time to go inside autopsy findings so we can better understand what the reports actually show. And to do that, we spoke once again with board-certified forensic pathologist Dr. Paul Uribe. Andrew's two autopsies follow the same broad forensic structure: external examination, evidence of injury, internal examination, microscopic and post-mortem annotations, and final findings. Joselson performed the original autopsy before embalming. Cooper performed the second autopsy after the first autopsy had already been completed and after the body had been embalmed and cosmetically prepared. The two autopsies broadly agree on many major observations. Both identify Andrew as a 20-year-old male, about 6 foot tall, weighing in at 180 pounds. Both describe multiple sharp force injuries. Both also recognize the neck and chest as central to death.
It's always interesting going back in time and looking at older autopsy reports and seeing how we've evolved, what we typically do better, how we do things differently, things like that. Joselson's report describes multiple stabbed and incised wounds. Most of the sharp force injuries here are pretty superficial. He numbers them for convenience sake only. How you number them doesn't really matter. It has no implication in terms of the sequence of the wounds or things like that, because it's very, very difficult to sequence wounds unless they're like hours or days apart from each other. If they're in rapid succession, it's very difficult to determine a sequence.
Let's dive in here. Before we begin, a quick warning. This section includes detailed discussions of autopsy findings and forensic evidence. The descriptions may be graphic or unsettling to some. Listener discretion is advised. Can you kind of walk us through the main autopsy that was performed on Andrew?
Sure. So we'll go in detail on wound number 1, and then we can use that framework to look at all of the other wounds as well. Wound number 1 he describes as a stab wound to the right anterior chest, so that's the right side of the front of the chest. It's a stab wound, so that means it's deeper than it is long. It's located on the right breast, and we localize that 20 inches below the top of the head and 4 3/4 inches to the right of the anterior midline. It's vertically oriented, meaning it's up and down. It measures 1/4 inch in length. Then he describes the depth of the wound, which is this is a superficial wound, not entering the chest. So he does not measure how deep it is, but it seems like it does not enter the chest cavity, so it's not particularly deep. It just injures skin and soft tissue only.
All right. So now, how do we compare that to wound number 3?
So number 3 is another stab wound of the right side of the chest. So 20 3/4 inches below the top of the head and 2 inches right of the anterior midline. So it's a little bit further below the top of the head, so it's a little bit below wound number 1 and 2 inches to the right. This one is horizontally oriented, measuring 5/8 inches in length. Medially, it's blunt. Laterally, it's sharp. He estimated the wound path is 3 to 4 inches in depth. That's enough, typically in most people, to go through the chest wall into the chest cavity and hit the lung. So when a knife goes through the chest cavity, it can cause the lung to collapse. You're entering air into the pleural space, so normally there's a vacuum in there which sort of pulls the lung open. When you introduce air into that space, the lung can collapse. When you penetrate the lung with a knife, that can cause bleeding. So not only do you have air in the chest cavity, but you also have blood. Blood from a stab wound to the lung can cause bleeding into the chest cavity and bleeding into the lung itself, including bleeding into the airways of the lung.
So in Joselson's report, I see a number of wounds on the chest. But it looks like wound number 3, the one that you were just talking about, wound number 4, and wound number 14 were the ones listed as fatal. So maybe we can look at number 4 next?
4 was on the left side of the chest, 21 inches below the top of the head, 3.5 inches left of the anterior midline. Horizontally oriented, both ends appear sharp, enters the left chest cavity, passes through the heart and the left lung twice, and it's an estimated 4 to 5 inches long. The fact that it enters the heart and left lung twice, in that part of the chest, that's where the lung sort of overlays the heart a little bit, and then the heart kind of sits behind it, and then there's also lung on the back end of it too. So that's why it looks like you can have almost like 2 different wounds to the left lung, but it's actually just the same wound, but it goes through the heart.
Ooh. I hear you describing this wound, and I mean, obviously it sounds awful. How quickly do you think this wound would have impacted Andrew?
With a puncture wound of the lung, you will still be able to move and feel things for a while. It's not going to cause you to lose consciousness within a second or 2 or anything like that. Even a stab wound directly to the heart, because that could bleed out slowly. And it depends on which part of the heart you hit too. If you hit the right side of the heart, that's sort of a low pressure system, so blood will just kind of ooze out from that. If you hit the left ventricle, which is like the big powerhouse pumping chamber of the heart, then you're going to lose a significant amount of blood with every pump of the heart. Let's see. Superficial stab wound in the anterior left lower pericardium, epicardium and myocardium, so it seems like anterior left, so it might have hit the left ventricle. It's kind of hard to tell exactly, but it hit the front of the heart around the area of the left lower pericardium. That's sort of in the area of the left ventricle.
So what I think I'm hearing you say here is that this wound would have caused serious damage, but not necessarily immediately incapacitating.
It would not be immediately incapacitating. Immediately incapacitating would be, I would think, penetrating injury of the brain or high cervical spine. Then, it's lights out, and injury of the cord of that area is you're not moving or feeling anything at that point. So a stab wound to the heart, although it is a significant injury and, like potentially very fatal, you need immediate medical intervention, including immediate surgery. It's not immediately incapacitating. Now, are we talking ability to maintain consciousness of 10 to 15 seconds after that wound? Sure. A couple minutes after that wound? Sure. 15 minutes? Yeah, maybe. But any longer than that, it's the heart. You're losing blood with every pump.
Yeah. Okay. Now, can we compare that with, let's see, wound number 14, I think it is, which was also reportedly fatal?
Wound number 14 is a deep incised wound of the anterior neck. It extends just above the thyroid cartilage, which is basically your Adam's apple, and just to the left of the thyroid cartilage, across the midline to the right, measuring about 4 inches in length. So he describes this as an incised wound, so it's 4 inches long, and it's not quite as deep. The right-hand margin has a W-shaped appearance, and no hesitation marks are associated with this wound. The W-shaped appearance could be a second contiguous kind of cut or slash, because one starts one part of the W, and then the other one, it's just one contiguous wound, and it measures approximately 1 inch in depth, so it could very well have hit one of the key vessels in the neck. Particularly looks like it would probably be the right side, but once again, you have to go back to the original autopsy photos and look at it. With wounds of the neck, you got to be careful because you have blood loss, and another thing that occurs in sharp force injuries of the neck is particularly of the jugular vein, because jugular vein is a low pressure system, so yes, you will have bleeding from it, but if it's exposed to the air, you can actually suck air into the system, into your cardiovascular system, and it goes right to your heart, and that's called an air embolism, so that's just something you have to be careful of, particularly with jugular vein injuries. If you have someone who dies of a sharp force injury of the neck and there's not a whole lot of blood at the scene, it's like, well, they easily could have gotten an air embolus. Talking about the neck, hemorrhage in the strap muscles, which you see with the sharp force injury there, does describe transection of the epiglottis. So the epiglottis is on the upper part of the internal neck structures, so it's the little flap that closes over your airway whenever you swallow, so you don't swallow food in your airway. So the transection of the epiglottis, that tells me the neck wound was pretty deep, and it went into the airway. So that would be one avenue of hemoaspiration, because you're bleeding into your airway. It can also explain why there's potentially blood in the stomach too, because if there's blood going down your airway at that level, you can also be swallowing it as well. So that explains that. One interesting thing to note is he didn't have that much blood in either chest cavity. It only described 50 milliliters of blood in the chest. Now that could be because he bled out at the scene, but if the scene was relatively clean, then it might be that while he had the stab wounds to the heart, it was the airway thing that got him, that he lost consciousness from that rather than the wound to the heart. But once again, that's a little bit of, dare I say, speculation, but that's just an example of why it's so difficult to sequence these.
One of the things that, as I ran this over in my head over and over, was there was a lack of blood. That I didn't see 6 liters of blood, which is what the average male has anyway. He wasn't bloody, I didn't think, at all. There was none on his wrist. None that I could see on his forearm or anywhere.
I also didn't notice a major amount of blood in that area. I would have expected to see a lot more blood. I mean, it may have all been absorbed into the bedding. And like I say, I didn't try to turn him or look for anything, but like I say, I didn't notice any on the floor. None that I noticed in the area.
I'm looking, thinking, I don't see any blood on this, at least on the outside. And I'm thinking, no major amounts of blood visible on the bed. It seems like there would have been a lot of blood everywhere.
Something I find really interesting in this whole report is that there's really no mention of hesitation wounds to the neck, much less really anywhere on the body. So I guess I'm curious if you can maybe briefly touch on this.
So, usually when people are cutting themselves, they'll leave what are called hesitation marks, which are like partial incisions because they're nicking their skin, or they might nick it because they don't know how far they need to cut or something like that. So they'll start cutting themselves and realize that, yes, cutting yourself does indeed hurt. And they'll get up the muster and go ahead and make a bigger cut through it. Commonly on the neck or on the wrists, you don't necessarily have to. In cases, I've done a number of sharp force injury suicides where sometimes you have them, sometimes you don't. If they're there, can they be very supportive of a self-inflicted sharp force injury? It could be.
You just mentioned the wrists, so I'm actually now wondering if we can maybe go a little bit deeper and zoom in on the wrists and hands here.
Okay, so we have the injuries to the wrist, which is wound 10 and 11. Vessels run very superficial along your wrist. That's why you can feel your pulse right there too. You have your radial artery right there. So he does not mention if the radial artery is hit on either wrist, but once again, these are definitely concerns. Let's see. So there's the 2 horizontal abrasions on the right third and fourth fingers, on the anterior aspect of the right second finger with attached flap of skin. So those could be sharp force. They could be what we call defensive type wounds too, which are, if someone's coming at you with a knife, what are you going to do? You're going to try and block it with your hands. So you can get wounds on the palm of your hand, on your fingers, things like that. Whether or not it's defensive, I always say defensive type injuries, because unless I'm there, I don't know what happened, but it could be consistent with that.
Wow. So, as I hear this, what's going through my head is that Andrew could have, in fact, been defending himself. Like, there is a chance with what we're seeing here.
It depends on the context. In this particular case, you have over 20 sharp force injuries, both incised wounds and stab type wounds, pretty much on the anterior surfaces of the body. So it's all areas that you can reach by yourself. Like, you can reach your temples, you can reach your neck, you can reach your chest. It's a little bit harder if someone has like 25 stab wounds in the back or something like that. It's like, yeah, okay. Could they do it themselves? Maybe. It would take some work to do, but how significant are these wounds? A lot of it's just context-based, and everything we do is context-based. So the fact that there are multiple wounds of the temple, it described 5 superficial stab wounds at the left temple, measuring up to 1/4 inch in length. Once again, could that be someone else stabbing him in the left temple with a knife? Sure, it could be.
So I guess it's worth noting here for listeners that there are some very small wounds on the forehead, kind of above the right eyebrow. There's a few others on the right side of the chin, and then we also see a few kind of on the back of the scalp. These seem relatively small and superficial, but I'm curious, in your opinion, is there anything unusual about the head in these reports?
It doesn't document any skull fractures, doesn't document any brain injury or anything like that. The reflected scalp shows hemorrhage in the left and right parietal areas, which is not quite where the temporal stab wounds were. So that could represent some type of blunt force trauma. It could be from what I call terminal collapse as well, which is where you collapse for the last time and possibly hit your head when you lose consciousness.
Hold on. Let's rewind this again.
Could be from what I call terminal collapse as well, which is where you collapse for the last time and possibly hit your head when you lose consciousness.
What would have caused something like this to happen? Did Andrew trip and fall like the DOJ report speculated? Or is it possible that someone did this to Andrew? Let me ask you this. Is it weird to you that Joselson doesn't acknowledge the x-rays?
He said that they were examined. That tells me that they were done and he looked at them. Now, once again, what are we looking for in postmortem x-rays in, sharp force injury cases? Namely, we're looking for part of the knife that broke off in the body, because that's one way you can determine, hey, this is the knife that actually caused this wounds. If you have a knife with a broken tip and you recover the tip in the body, then that means that's the knife that caused everything. And it's very possible it could have been missed too. Or when did the tip of the knife break off? Was it due to this, or was it, before that? I don't know. These are some of the considerations, but we generally believe it's good practice to get radiology in sharp force injury cases.
I'm glad you mentioned this, because this is one of the things that I know we've talked about with the family previously that they have had kind of questions around. Dan had previously told us, I still don't know if
the knife that they found was the knife that was actually used based on wound size and depth, especially because the knife that was found, the knife that I had given him, was missing the tip. And I can tell you right now, when I gave him the knife, it had a tip. I guess there's a part of me that thinks that, man, did they ever x-ray Andrew's body to see if that knife tip was in his body? Did they actually look around the room to see if there was any weird things, like where the knife may have cut into something and maybe the tip was there?
So when you look at a body, Can you ultimately determine what hand stab wounds are ultimately made with? I guess assuming we're following this suicide narrative?
It could be done by either the left or right hand. Generally, stab wounds or short force injuries, with rare exception, could be caused by either hand.
Joselson's report, I guess, ultimately says that the cause of death is stab wounds to the neck and chest. Based on kind of what you're seeing in this report, what do you make of that?
My only difference would be a more semantic difference, and I would say multiple sharp force injuries. It's a small preference. The main point is he's saying that the stab wounds of the neck and the chest were the most significant ones. All of the others are superficial and not fatal. I know it's a semantic thing, but forensics is very semantic in terms of definitions, so we try and stick with the definitions as much as possible, because he said the incised wound is on the neck, so why are you calling it a stab wound to the neck?
Now, this is where I'd like to kind of compare the two autopsies for a moment. I think one of the biggest things that Cooper, the privately hired pathologist, brings up in his report is around lividity. Can you help me understand what is lividity and give me your take on what you make of the differences in the mentions of lividity in both reports?
So lividity is post-mortem pooling of blood. So when you die, your circulation stops and blood just kind of sits there. Over time, it settles down to the lowest points of the body. So say if you're lying on your stomach when you die, then blood is going to go towards your front and settle. Now that manifests itself in a pattern called lividity, which is a red discoloration of skin. There is a period of time where lividity starts to set in after death, and for a period of about maybe up to 6 hours, it largely depends on the environment, where it's called blanching lividity, where if you take a dead body and push on the redness of lividity, it will kind of separate and become pale, like you're pushing the blood out of the way. After about 6 to 12 hours, that lividity becomes fixed, where if you press on it, it no longer blanches, and it's just kind of settled in the tissue that way. Can you use that to relatively determine time of death? Sure, maybe within like a window of 6 to 12 hours. It's really tricky. In Joselson's report, he doesn't describe lividity, I don't think, at all. You can get a little bit of change in lividity, but you don't have an adequate assessment of lividity when the body was found by someone who is trained to assess lividity. Joselson doesn't count on it, and Cooper's assessment of lividity roughly a month later, after the body was embalmed, you can't put too much stock in the lividity difference there, because there's way too many variables.
Well, Yolo County separately said that Andrew's lividity was, positionally dependent and blanched readily to intense pressure. So,
I mean, if that's the assessment there, then at least they looked and they described it properly, like someone who knows what they're looking for. So that tells me that he died, I don't know, you can't use it as a good time of death estimate, but he wasn't there 2 days. Based on lividity, based on the environmental temperature and everything like that, he probably died a couple hours before, and a couple could be anywhere from like 6 to 12, something like that. I can't narrow it down any more than that based on lividity, but any assessments that Cooper makes on lividity after about a month and after the body was embalmed, yeah, that's a stretch.
So outside of lividity, if we're looking at Joselson's autopsy next to Cooper's, how do they compare ultimately?
They're largely similar. There are some differences. Some of it could be explained by the fact that Cooper's doing a second autopsy on an embalmed body. Second autopsies are always problematic because things are removed and you're sort of having to reconstruct a lot of things. But generally, the cause of death is the same, multiple sharp force injuries. Cooper does describe the upper wound to the neck and then stab wound to the heart. Doesn't necessarily mention the stab wound to the lungs, but that's kind of hard to verify on second autopsy because the lungs are already taken out and sectioned and everything. The objective findings, I mean, they're very similar to the original autopsy report. There are some differences, like Cooper's autopsy demonstrates blunt force trauma to the right temple, whereas originally they were described as 5 stab wounds to the right temple. That's significant. Cooper describes a blunt trauma to the right arm, which isn't described in the original autopsy report. Also has an abrasion of the lower lip, and not quite as much hemoaspiration in the lungs as well. But other than that, he describes sharp force injuries, some blunt trauma, namely the blunt trauma of the right temple. Is that due to stab wounds or is it due to blunt force? I don't know, because he describes blunt force injury of the right temple when it was originally described as 5 stab wounds to the right temple. And it's like, well, that's a pretty significant difference.
So there was kind of a mention in Cooper's report about the eyes. There's trauma to the left and right eyes. It seems like the right eye is confirmed post-mortem, but the left eye...
Yeah, Cooper describes the right globe, which is collapsed due to post-mortem needle extraction of vitreous, which is normal post-mortem. The globe of the left eye shows penetrating injury with disruption of the sclera and extraocular muscles. This was not seen in the original autopsy, so he did microscopic examination, which makes it seem like it's a post-mortem artifact of some kind. The right is post-mortem, the left seems to be post-mortem. I mean, I would like to think that if his left eye was collapsed due to trauma, that would be something that's noted in the original autopsy report. I try not to assume things, but that is one of those findings that just sort of stands out.
First thing I noticed was that his head was looking up and his left eye was open. I think it was his left eye. I'm pretty sure it was the left eye. One of his eyes was open.
One eye was exposed, and it was open and not reacting or blinking. And even though it was open, you could see the white of the eye. It wasn't like an alert, live person's eye.
So blunt force versus 5 stab wounds, some discussion around the eyes, obviously some mentions of lividity, seem to be where the differences of opinion lie. Anything else?
The biggest interpretation difference is the manner. And, once again, Josselson, since he works in a coroner's office, he does not need to worry about manner of death, whereas that is the main brunt of Cooper's opinion. And a lot of Cooper's opinion is based on the histologic dating of injuries, which is inherently problematic. The theory is that the body responds to injury in a relatively sequential way. Like it starts off with edema, and then you might get some acute inflammation, and then you get the more chronic inflammation and reconstructive elements in there. But it doesn't follow an exact timeline. It follows a very relative timeline. We can't date injuries within hours. That's just not possible. My biggest issue with Cooper's report is the interpretation of the collective findings of the case and what does it actually mean. And a lot of it was based on timing from histology, which is really problematic. So much at the end that he says he was most likely killed 12 to 30 hours before removal of the body. Based on what? What is that based on? I have no idea. And even then, blanching lividity, you're not going to have blanching lividity 30 hours afterwards. It's going to be well fixed by then.
Dr. Paul, this has all been so extremely helpful. It's really good to be able to kind of go through and understand this all a bit better, especially through an expert's eyes like yourself. It's so tricky because as I hear some of what you're saying, I am able to understand and kind of follow along with these ideas that lean suicide. But there's also so many other questions here, so many things kind of outside of the autopsy that make me go back and forth. And it's just, it's so tough.
Yeah. Now, one of the things that I've taught before is the mantra, whenever you look at a suicide case, you always think dirty. Like, okay, I have to convince myself this isn't a homicide. How? So you look for the clues that don't fit. Is there evidence of a struggle? What other clues are there that suggest foul play? Particularly whenever we come into the realm of stage suicides. You actively look for the things that don't fit. Suicides have certain connotations for the family and things like that. So if I call something a suicide, I'm pretty damn sure it's a suicide. To be competent in death investigation requires training. It requires experience. It requires knowing what to look for, what not to look for, both from a death investigative standpoint and from a law enforcement standpoint. Now, one of the big questions is, okay, it was investigated by campus police. How much training have they had in death investigations? How much training have they had in homicide investigations? How many homicides have they investigated before? How many death scenes have they responded to? Do they know what they're looking for? That type of thing. This is not a unique problem. This is a problem in all sorts of jurisdictions with varying amounts of support, varying amounts of training, and things like that. If you look at something with new, fresh, unbiased eyes, sometimes that's helpful, and sometimes that's all it takes.
Sounds like it's time to think dirty.
Just think dirty. You got to think worst case scenario.
On the next episode of Love and Justice, the autopsies tell us what happened to Andrew's body, but it cannot fully reconstruct what happened inside room number 12. Now, we're adding another expert to the team, a crime scene reconstructionist, to help examine whether the physical evidence tells one story or something else.
I have reached out to 4 different companies who specialize this, and I got a response.
I just have a lack of words, even in the year 2001, for the lack of professional documentation. The level of detail that they pulled out of this crime scene is almost a crime in and of itself.
Love and Justice is an official production of Magic Lamp Productions and is primarily recorded in California. This episode was executive produced and hosted by me, Kyle Olson. Supervising producer, Alexa Lopez. Producer, Lisa Visione. Edited by Cody Crabb. Special thanks to Dr. Paul Uribe. Additional special thanks to Amanda Crabb, Bob Greatrix, Brandon Allen McClanahan, Carlos Vera, Ethan Rosenberg, Haley Gabby, Mick Alpert, PJ McCabe, Richard Leibichin Jr., Roxanne De Palma, and Stephen Paul. Don't forget to subscribe to this podcast and rate it 5 stars. Every single review greatly helps our exposure and helps us share Andrew's story with a larger audience. So please rate this podcast and share it with your friends today. If you have a tip, question, or thought, please call our hotline at 209-764-5683. That's 209-764-LOVE. Until next time, thanks for listening. This episode covered difficult material. If it brought up anything for you, please reach out for support. In the United States, you can call or text 988 to reach the 988 Suicide and Crisis Lifeline, available 24/7 for free and confidential help. You can also chat with someone at 988lifeline.org.